Hey guys, Jeremiah here with part 2 of our step-by-step breakdown of a trauma assessment. If you haven't watched part 1 of this video, make sure you do. In part 1, we covered the scene size up, we covered primary survey resuscitation, and we covered history taking. So we covered the first part of your trauma assessment sheet. So right now we're at the secondary assessment. Remember, the purpose of the secondary assessment is to perform a detailed physical examination of your patient. That exam should cover the patient head to toe, front to back, and we're looking for any injuries. One of the things you guys are going to notice when I perform this skill, very thorough and detailed with the head. Another thing that I do a little bit differently, you're going to see me assess the shoulders and the clavicles. It's not on the sheet, but I think it's important to do so. It's how I practice out in the field. One of the things to note, if you have someone who suffers from a broken clavicle, they have a fracture of their clavicles, if it's severe enough, you can actually puncture a lung. So for me, I think it's pertinent to actually assess the shoulders, assess the clavicles. I know it's not on the sheet, but it's not going to hurt to do it. All right, again, it's going to help to show competency. So I recommend that you perform the skill like I do in this video. But remember, at a minimum, you have to do what's on the sheet. There's nothing wrong with doing a little bit extra, though. All right, so we're at the secondary assessment. When you get here, I want you to say that you are going to check your patient head to toe for DCAP, BTLS, and crepitation. And then I want you to let the proctor know what DCAP, BTLS stands for, and if they ask, let them know what crepitation stands for. If you don't, your proctor's probably going to ask you, so you might as well just knock it out of the way, get it out of the way, and tell them. So when you walk in, say, I'm going to now begin my secondary assessment. I'm going to check my patient head to toe for any DCAP, BTLS, and crepitation. DCAP, BTLS stands for deformities, contusions, abrasions, punctures and penetrations, burns, tenderness, lacerations, and swelling. So you're going to look over your patient for those things. The other thing you're checking for is crepitation. Crepitation is the sound or the sensation of broken bone ends rubbing against one another. If you are ever in a situation where you have to perform CPR, especially CPR on an elderly person, it's not uncommon to feel crepitation, to break ribs if you're doing CPR adequately. You might feel the cartilage pop on both sides of the sternum where it connects to the rib cage. That is your sensation, that's your crepitation. Alright, so you're beginning your secondary assessment. You're going to check your patient head to toe for DCAP, BTLS, and crepitation. Alright, you're going to begin the skill by checking the head. So when you get here, I want you to say, I'm going to check my patient's head for DCAP, BTLS, and crepitation. I'm inspecting the front of the head, sides of the head, back of the head, top of the head for any DCAP, BTLS, and crepitation. Now, because my hands went behind the patient, not a bad idea to pull them out and ask the proctor if there's any blood on your gloves. You don't have to, but you can if you want. Another thing you want to do is inspect the scalp. You're also going to inspect the ears. So when you get to the ears, what you're doing is looking for any blood or CSF coming from the ears. You also want to look for any bruising behind the ears. We call that battle signs. Okay, so you're checking the scalp, you've checked the head, come around and you want to check the ears for any blood or CSF. CSF stands for cerebral spinal fluid. It's produced in the brain, it's stored in the ventricles of the brain, and the purpose of CSF is to protect, nourish, and bathe the brain. So what CSF does is it actually provides a barrier between the brain and the skull, and it's going to provide a little bit of cushioning in the event that your head makes impact with anything. All right, so we'll assess the ears for any blood or CSF, and we're looking for any bruising, also called battle signs, behind the ears. One way you can assess for CSF, from what I've read, I've never actually seen it out in the field. If you had bleeding coming from the ears, the patient was bleeding, you would take a 4x4 piece of gauze, and you would place it underneath the ear and you would let the blood drip onto the 4x4 piece of gauze. And what they say is when the blood drips on the gauze, on the outer edge of the blood around it, you're going to see a halo. and the halo may appear to be a yellowish or off-white color. That is what you're looking for when you're checking for CSF. Again, personally, I haven't seen it out in the field. Remember, your CSF is going to be clear, it's colorless, so you may have a hard time detecting it. Okay, so again, we've checked the front of the head, top of the head, sides of the head, behind the head for any decap, BTLS, and crepitation. We're also checking the scalp. I want to know if there's any blood on my gloves. We're also going to check the ears for any blood or CSF, and we're going to look for any bruising behind the ears. We call that battle signs. Next, we want to assess the eyes. All right, so what we're checking for is we want to see if the pupils are equal and round and reactive to light. So the acronym we use is PEARL, P-E-A-R-R-L. We're checking to make sure the pupils are pearl. Another thing we want to look for is any bruising around the eyes. Remember, bruising is a late sign, but still we want to check. Right, that can indicate that there was a serious head injury. So you're going to check the pupils for pearl. All right, you're going to use your pen light for that. And we want to look for any bruising around the eyes. We also call that raccoon eyes. Then come down, check the face, check the cheekbones, check the maxilla, the upper lip, check the mandible, that's the jaw. All right, we're going to assess the mouth, nose, and the rest of the face. All right, again, we're checking for decap, BTLS, crepitation. While we're at the mouth and the nose, we want to make sure that our oxygenation, our O2 therapy is still adequate. And you're going to look in the mouth for any obstructions, any blood, teeth, vomit. Look in the nose for any obstructions, any secretions, any bleeding. And then we can move on. All right, so we've checked the head thoroughly. When you come down to the neck, you want to check the neck for decap, BTLS, and crepitation. You're also going to look for tracheal deviation. Right, so in the event of a pneumothorax, the trachea may shift from midline towards the good lung. Okay, so if you have a patient who has a collapsed lung or a pneumothorax, if the right side is collapsed, you may actually see the trachea shift towards the patient's left side, towards the good lung. So we're checking for tracheal deviation. We're going to look for jugular vein distension. Again, that can indicate that the patient has a pneumothorax. And we're also going to look for step-offs. So we're feeling behind the neck for any vertebrae that are out of alignment. That is what we're calling a step-off. Right, so when you come down to the neck, you're checking the neck for any decap, BTLS, and crepitation. You're going to look for any tracheal deviation. You're going to look for jugular vein distension. And you're going to check for any step-offs. All right, now we're at the neck. It's really important to remember you need to apply a cervical collar. So remember, we would have a partner here holding C-spine. You want to make sure that you measure your cervical collar. Make sure that it's the right size. And then while your partner's holding C-spine, you're going to have to slide this collar into place and apply it. All right, when you get to this point, if the proctor tells you consider it done, then you don't have to go through the motions. But if the collar's there, make sure you measure and you apply it. Okay, so we've assessed the neck. Now we're going to come down and check patient's shoulders. So we're checking the shoulders for any decap, BTLS, and crepitation. We're also going to check the clavicles for any decap, BTLS, and crepitation. Not a bad idea to expose your patient while you're here. When you're checking the shoulders and the clavicles, if your patient hasn't been exposed already, make sure you do so. Next, we need to check the chest. So when you get to the chest, you're going to inspect the chest, right? We're inspecting, we're looking for equal bilateral rise and fall of the chest, right? We're going to look for any bullet holes, any decap, BTLS, crepitation. All right, then we're actually going to palpate, all right? So now we're going to palpate. I'm being cautious of my GSW. And again, I'm checking the front of the chest, right, around the rib cage and the sides for any decap, BTLS, crepitation. Next thing I want to do is check the sternum using a chopping motion. Right, again, we're making sure the sternum is intact. And then I want to look for any paradoxical motion. So paradoxical motion is going to be unequal chest rise. Right? Again, you may see that if your patient has a collapsed lung. You're going to see the unaffected side rise while the affected side does not. And then lastly, you also want to make sure that you check for flail segments. The definition of a flail segment is 3 or more ribs broken in 2 or more places. Okay? 3 or more ribs broken in 2 or more places. So generally what that means is you're going to have sections of rib, 3 ribs, that are going to be broken on each side. And what that does is it creates a free-floating section of rib. Okay? So you want to check for any flail segments. As an FYI, in the real world, if you had a patient who is suffering from a flail chest or a flail segment, the way that we manage that would be by splinting it, and the way you're going to splint that is by placing a pillow over the flail segment and then taping the pillow to the patient's chest. Remember, make sure you don't tape it too tightly. You want the patient to be able to inhale and exhale comfortably. Okay, so after checking the shoulders, we're going to come down and assess the chest. We're going to inspect the chest first, then we're going to palpate for any decap, BTLS, and crepitation. Okay, then we want to check the sternum using a chopping motion. Okay, we're going to look for any paradoxical motion. We're going to look for any flail segments. And then lastly, it's really important that you auscultate lung sounds. So what you're going to need to do, again, you need to demonstrate how you would go about performing these skills. Put the stethoscope in your ear, and you're going to auscultate lung sounds. Remember, we always compare one side to the other. So if I was checking the patient's upper right lung, I would then check the upper left, lower left, lower right, and then we're going to check mid-axillary. Mid-axillary is a few inches under the armpit. All right, when you do that, your proctor should then advise you of your patient's lung sounds, if there are any. Okay, so the chest, inspecting it. Then decap, BTLS, crepitation. Okay, be careful of your sucking chest wound. Check the sternum using a chopping motion. And we're going to stop and look for any paradoxical motion. We're going to look for any flail segments. Then we're going to auscultate our lung sounds in 6 spots. Next, you're going to come down to the abdomen. You want to assess the abdomen for decap, BTLS, distension, and rigidity. Right? Because the abdomen doesn't have a lot of bone structures in it, we're not checking for crepitation. Instead, we're checking for distension and rigidity. Distension can indicate that your patient has had a hollow organ which is bursted. Rigidity can indicate that your patient has internal bleeding. Remember, if you're bleeding internally, as the blood sits and it coagulates, as it clots, it's going to create a rigid abdomen. In order to assess the abdomen, you need to take one hand. Okay, take your fingers, you're going to place them over your other hand, over your fingers. Then what you want to do is press and roll. Right? So you're pressing relatively firmly on the abdomen, and what you're doing is you're pressing and you're rolling, and you're trying to feel the structures that lie beneath the skin. You're trying to feel the organs beneath the skin. Okay, and again, you always want to compare one side to the other. So I'm going to inspect, or I'm going to check the abdomen for decap, BTLS, and crepitation. I'm checking the patient's upper left quadrant, upper right, lower right quadrant, lower left quadrant. And another thing I do is I like to assess the bladder. Again, checking the bladder for decap, BTLS, distension, and rigidity. All right, so that's the abdomen. At a minimum, you need to check all 4 quadrants. Okay, after you check the abdomen, you need to come down to the pelvis, right? The way that you check the pelvis is by pressing in, okay, in and down, okay? So you're assessing the pelvis as a unit, as a whole. So press in and down. You don't want to try to open it up, fan it open it up like a phone book. Remember, there's vasculature that passes through the pelvis. If the pelvis is damaged or fractured, and you try to open it up or you press down and pull away, you can rupture a major artery. So we're going to inspect the pelvis for decap, BTLS, and crepitation by pressing in and down. Next, you need to assess the genitals, and the way we do that is by performing a genital sweep. So when you get here, you're going to say, I'm going to assess the genitals using a genital sweep, and what you're checking for is an erection in males. We call it a priapism. So you're checking for an erection in males or hemorrhaging in females. Okay, so I've checked the pelvis for decap, BTLS, and crepitation using an in and down motion. I'm now going to assess the genitals using a genital sweep, and I'm checking for priapism in males and hemorrhaging in females. Okay, next, per the sheet, you need to check the lower extremities. There's no reason why you can't assess the lower extremity from the side of the patient that you're on and the upper extremity. I know it says do the lower extremities first. Remember, you're not supposed to reach over your patient, so it's going to eat up some of your time if you check this leg, walk around, and check the other leg. So it's my recommendation while you're here, you check the patient's lower leg and you then assess the arm from the side that you're on. So when you get to the leg, okay, you're going to use your hands, make sure you wrap all the way around as much of the thigh as you can, and you're checking patient's right leg, top to bottom, for any decap, BTLS, and crepitation. Another thing you need to assess for is PMS, pulse, motor, and sensory. Right? It's important that we check to make sure that the patient has pulse, motor, and sensory functions in all four extremities. Now, when you do this, if your patient's unconscious, your proctor is probably going to advise you your patient is unconscious, there's no response. You still need to check for PMS in the other three extremities. Don't just skip it because your patient's unresponsive or unable to respond. So when you get here, you're assessing the leg top to bottom for any decap, BTLS, and crepitation. I'm going to assess for a pulse. I'm going to assess for motor by asking the patient to wiggle his toes. And sensory, I'm going to ask if the patient can feel me squeezing. Another thing to remember, if you get here and you assess for a pulse and the proctor advises you that there's no pulse, you need to check for a central pulse. So you would come up here, you would insert your fingers in the gap, in the collar, and you're going to assess for a carotid pulse. Right? When you get here, if your patient had an injury to a limb, maybe they're in shock, right? There is a chance that they may not have a peripheral pulse. Right? It can happen where your patient doesn't have a pulse in the foot, but they have a central pulse. Or they're in cardiac arrest. Right? So that's why it's important we check. You want to make sure that your patient's heart hasn't stopped beating. So if you ever get to a point and you're assessing an extremity and there's no pulse, make sure you verbalize that you're going to check for a carotid pulse. So again, check it in the leg, top to bottom, for any decap, BTLS, crepitation. I'm going to assess for a pulse. My patient has shoe and sock on, I take it off. I'm assessing for pulse. Motor, can you wiggle your toes? Sensory, can you feel me squeezing? I'm going to assess my patient's upper right arm. Lower right arm for any decap, BTLS, and crepitation. I'm going to assess for a radial pulse. Remember, your radial pulse is on the thumb side. Motor, I'm going to ask the patient to wiggle their fingers. Sensory, I'm going to ask if they can feel me squeezing. Again, this patient's unresponsive, so we have no response from them. You're going to walk around your patient. You're going to assess the patient's upper and lower left leg for any decap, BTLS, and crepitation. Let's say I get here and the proctor advises me that I have crepitation to the lower left leg. I'm going to note it. And remember, something like this, something like a fracture, is going to be a secondary injury. So we're going to treat that later. So if you get here, you get anywhere, and there's a secondary, a minor injury, you're going to treat it later. So I'm checking the leg for decap BTLS crepitation. I take off the shoe and I'm checking for a pedal pulse. Motor, can the patient wiggle their toes? And sensory, can you feel me squeezing? I'm going to assess the patient's left arm, top to bottom, for any decap BTLS and crepitation. I'm assessing a radial pulse. Motor, can the patient wiggle their fingers? Sensory, can they feel me squeezing? All right, so we've assessed our patient head to toe. Now we need to check the patient's posterior, thorax, lumbar, and buttocks. So in order to check the patient's backside, we need to log roll our patient. As a general rule of thumb, you never roll your patient on an injury. To this day, I teach my students that. Don't roll your patient on the side that they have an injury. All right, it's a general rule of thumb. Some people will argue that if your patient has a collapsed lung, okay, in this scenario, patient has a GSW to the left side, and they most likely have a collapsed lung. So when that's the case, some people will argue rolling the patient on the injured lung because they don't want to compromise the good lung. If you're going to do that, make sure you verbalize and you explain why in your scenario. Okay, I don't recommend it. That's just how I do things. It doesn't mean that you have to do it my way, right? Because this patient has an injury to the left side, they also have an injury to their lower left leg, I'm not going to roll the patient on it. So I'm going to roll the patient towards me. When you're rolling a patient, you're going to have a second rescuer, you're going to have a partner with you. And the way that we log roll our patients is always on C-spines count. And what you want to do is grasp your patient up by the shoulder. You would grasp down at the knee, and then my partner would kneel alongside of me, and with their left hand, they're going to reach over and grab the patient at their waist, and they're going to use their right hand and grab the patient down by the ankle. And together, we're going to log roll our patient on C-spines count. So we'll use my imaginary partner. On C-spines count, we'll log roll the patient towards me. Make sure you're clear about when you're rolling them, right? So it's not just on C-spines count, but on 3. Okay, so 1, 2, 3, we log roll the patient. While you're here, even though the sheet doesn't say it, I like to recheck the back of my patient's head and neck for any decap, BTLS, and crepitation. Okay, then I'm going to check the posterior. Checking the thorax for any decap, BTLS, and crepitation. I'm going to check the patient's lumbar spine for any decap, BTLS, crepitation. I'm looking for any step-offs. I'm going to check the buttocks. I'm going to check the back of the legs for any decap, BTLS, crepitation. I'm going to look for any rectal bleeding. Right? And another super important thing to do, if you don't do it, you're going to fail. We had a penetrating injury to the front, so we need to check for an exit wound. Okay? So anytime you have any penetration to the patient's anterior side, make sure you look for an exit wound. So when you get here, you're checking head to toe for any exit wounds. If you found an exit wound, right? Generally exit wounds are going to be much bigger, maybe a little messier. So when you get here, the way that you would manage or treat it would be to take a bandage and you're going to place it over the wound and you're going to tape it on 4 sides. All right, you're not going to do an occlusive here. If you did an occlusive 3-sided dressing on the back, it's not going to create a functional flutter valve on the front. So when you get here, if you find an exit wound, treat it by covering it with a bandage. Because our patient's on the side, you can verbalize that you would insert the backboard. And then on C-spines count, you and your partner are going to log roll the patient onto the backboard. So on 3, 1, 2, 3. Okay, so we just completed our head-to-toe assessment. So right now we are at managing any secondary injuries. All right, so when you get to this part, you need to verbalize that you're going to manage any secondary injuries appropriately. So in this case, because I mentioned before, my patient had a fracture of the lower left leg, you would say, I'm going to manage any secondary injuries. I would do that by splinting my patient's left leg. It's that simple. If your patient had minor capillary bleeding somewhere, you would treat that with a bandage. So I'm going to manage any secondary injuries, and then the last section of the sheet, we move down to our reassessment. When you get here, what you need to do is verbalize how often you would reassess your patient. So when you get here, you're going to say to your proctor, because my patient is an unstable patient, I'm going to reassess him every 5 minutes. If your patient was stable, you would reassess your patient every 10 to 15 minutes. All right, guys, so we completed our secondary assessment. We managed any secondary injuries, and we did our reassessment. So what I'm going to do now is the secondary assessment, head to toe, so you can see how it flows. Let me take my collar off here. All right, so you get to the secondary portion of the sheet. You're going to walk in and say, I'm at the secondary assessment. I'm now going to check my patient head to toe for any DCAP, BTLS, and crepitation. DCAP, BTLS stands for deformities, contusions, abrasions, punctures and penetrations, burns, tenderness, laceration, and swelling. Crepitation is going to be the sound or the sensation of broken bone ends rubbing against one another. So let's start with the head. Again, your gloves would be on. I'm going to check front of the head, sides of the head, back of the head, top of the head, and the scalp for any DCAP, BTLS, and crepitation. So any blood on my gloves. I'm also going to assess my ears for any blood or CSF coming from it. I'm going to look behind the ears for any battle signs. Is there anything noted? Then you're going to come up and you're going to assess the eyes using a pen light. And you're assessing to see if the pupils are equal and round and reactive to light. We're also going to look for any bruising around the eyes. We call that raccoon eyes. Then we're going to assess the front of the face, sides of the face, the cheekbones, the maxilla, that's the upper lip, the mandible, the lower jaw. Right? We're going to assess the nose and the mouth. And again, we're checking the face for any DCAP, BTLS, crepitation. We're going to check the nose for any blood, any obstructions, any mucus. We're going to look in the mouth for any blood, teeth, vomit, etc. We also want to make sure our O2 therapy is adequate. Come down to the neck. We're checking the neck for any DCAP, BTLS, and crepitation. Right? I'm going to look for any tracheal deviation. I'm checking for JVD, which is jugular vein distension. And I'm going to assess for any step-offs. Because of the potential for cervical spine injury, I'm going to measure and apply the appropriate cervical collar, making sure that's snapped in. And again, you're going to have a partner holding C-spine, so you're going to have to slide the collar in. Slide the collar into place and make sure that it's secured appropriately. Come down, check the shoulders and the clavicles for any DCAP, BTLS, and crepitation. Now we're at the chest, so we're going to inspect the chest for any DCAP, BTLS, and crepitation. Then we're going to palpate the chest for any DCAP, BTLS, and crepitation. Checking the upper chest, we're going to be careful of our sucking chest wound. We're going to check the ribs, and DCAP, BTLS, and crepitation. We're then going to check the sternum for the same, DCAP, BTLS, and crepitation, and we're using a chopping motion. Okay, while I'm here, okay, we need to inspect for any paradoxical motion. It's going to be unequal chest rise. We're going to inspect for any flail segments. Okay, again, flail segments are going to be broken ribs on each side. The rib is broken on each side. The textbook definition, checking for 3 or more ribs broken in 2 or more places. We're also going to auscultate for lung sounds. Upper right, upper left, lower right, lower left, and mid-axillary. Okay, now you're going to move down to the abdomen. We're checking the abdomen for DCAP, BTLS, distension and rigidity. Checking the patient's upper left quadrant, upper right, lower left, and I'm checking the bladder. Now you're going to come down to the pelvis. So we're checking the pelvis using an in and down motion for any DCAP, BTLS, and crepitation. We're going to check the genitals by performing a genital sweep. Okay, on the back of my hand, I'm looking for a priapism in males or hemorrhaging in females. Next, I'm going to check the patient's leg, top to bottom, for any decap, BTLS, crepitation. Take the shoe off, checking for a pulse. Motor, can the patient wiggle his toes? Sensory, can they feel me squeezing? Checking the patient's right arm, top to bottom, for any decap, BTLS, crepitation. Checking for a radial pulse. Motor, can the patient wiggle their fingers? Sensory, can they feel me squeezing? I walk around my patient. Check the patient's left leg for any decap, BTLS, crepitation. If I find crepitation or an injury, I'm going to note it. I'm going to check for pulse. Motor, can the patient wiggle their toes? Sensory, can they feel me squeezing? Checking the patient's left arm for any decap, BTLS, crepitation. Checking for a pulse. Remember, if there was no pulse for some reason, we would check for a carotid pulse. Again, you check on the side of the patient that you're on. Pulse is present, so we note that there was no pulse on the left arm. Motor, can the patient wiggle their fingers? Sensory, can they feel me squeezing? Now we need to check the patient's posterior. So on C-spine's count, on 3, we're going to log roll our patient. Again, you would have a partner doing this with you. 1, 2, 3. We're going to check the back of the patient's head and the neck for any decap, BTLS, crepitation. I'm checking the thoracic and lumbar spine for any decap, BTLS, crepitation. I'm looking for any step-offs. I'm going to check the buttocks and the back of the legs for any decap, BTLS, crepitation. I'm going to check the buttocks or the rectum for any bleeding. And I need to check for any exit wounds. Next, we would insert our long board. And on C-spine's count, we would log roll the patient onto the board. So on 3, 1, 2, 3. At this point, we would now manage any secondary injuries. I would do that by splinting my patient's lower left leg. Now we'd move on to the reassessment. So this patient is an unstable patient, so we're going to reassess every 5 minutes. And that's it, I'm done with this station. All right, guys, so we just completed the secondary assessment and the reassessment portion of the sheet. That is it for our step-by-step breakdown of a trauma assessment. I hope you found this video helpful. If you did, make sure you give it a thumbs up. Make sure you subscribe, recommend it to others. And as always, take care, be safe.